Hi guys, good evening. Can you all see me and hear me? Just trying to log in and see your comments. Just give me a confirmation if I am visible and audible to you all. So wishing you all a very good evening, and I hope, yeah, so I think we are good to go. Just give me a quick confirmation in the live chat if we are. Um, So what we're gonna do is now discuss the radiology questions of NEET PG. Most of the recall, I'm sure, is out now, and there's a lot of speculation about what will be the cutoffs and everything. So one very sincere advice is don't take them very seriously because it's always very variable, right? Not every question that we are going to discuss is how it turned out to be, how it actually was. There could be minute details that we're missing out because most of these recalls are going to be memory based. So one very sincere advice to all of you is don't think too much about your expected rank and the cutoffs and the predictions of the ranks. Just don't fall into those traps at this point. Just let it go. All right, so now is the time when you just let go and take a break. Just forget about whatever has happened in the past. Try and learn from where you went wrong if you did, and move on. All right, so we have another exam which is coming up in the next month or so, which is INICT. So I think that is something which is going to be important. Not the whole 200. This is predominantly radiology, but if you look at radiology and allied subjects, guys, it had 25 questions. So I'm going to discuss 26 questions for you, which is like 1/8 of the paper. So if you consider 1/8 of NEET PG getting solved by a short subject, a very short, cute subject like radiology, I think that is a very big deal, isn't it? That is something that you would now want to take away, because even if you see the FMG exams, you see the INICT, if your radiology is strong, I think a lot of your subjects like surgery, medicine, pediatrics, a lot of your questions get answered. Orthopedics, so much overlap is there, right? So from now, the one learning point is you pay attention to my classes. All right, so you pay attention and you get 1/8 paper correct. That is very good odds, I think, of doing one short subject well, if that gives you like 1/8 of the paper correct. All right, so we'll begin the discussion. So I'll be looking out for your inputs if there are any other things that I'm missing out on based on the recall, and we'll work from that. All right, so yeah, many confusing options, they'll always be there, right? So it's always either the questions are difficult or the options are difficult. It can't, your life is not going to be very smooth where everything will be very simple and straightforward, right? So there's always going to be some trap here and there that we have to find out our way from, and that is what we have to learn. Yeah, all right, so let's begin. So before we begin the questions per se, plus subscription on an academy. So those of you who have not downloaded the app yet, definitely do that, and you can combine it with Prep Ladder to get iconic subscription. So if there are any juniors who are looking out for plans, so this is something that you should definitely consider, because you get two very good platforms together, and I think that serves as a one-stop shop for all your coaching requirements. Apart from that, we have special classes on the app, which are free classes for everyone, which are pretty useful, I would say. So definitely try and catch them. Nothing to pay for it, so just definitely catch them. And these are the two upcoming batches, which are for FMG and Next 2022. So these are detailed batch courses targeting these two examinations, right? So thank you so much, Sabreen and Saurav, for your kind words. And alright, so we'll talk about that. Let your results come, and before your counseling, we'll definitely have multi-subject sessions on what are the pros and cons of different specialties. So that is definitely something we'll take when the time is right. Okay, those of you are considering subscriptions, guys, these are the offers which are ongoing, so you can definitely make the use of them, and you can use my code, which is ZBORA or ZBORA Live, to get an additional 10% off. Alright, so having said all of these things, let's begin. So the very first question was an image-based question, wherein you had a patient who's presenting with abdominal pain and distension, multiple air fluid levels are seen, and dilated loops have been shown, right? So what are the dilated loops? So again, something which is expected. Most of the questions have come from highly expected, anticipated topics as far as radiology is concerned, and there's not a single question that you can say is something which was out of the blue or ye kya ho gaya kind of question. So what we have here are these centrally dilated bowel loops, isn't it? Just a second. Yeah, so these are the, just give me 1 minute. Yeah, these are the centrally located bowel loops which are having these valvulae conniventus, isn't it? So yes, as most of you are correctly saying, when you see central bowel loops, complete folds, these are nothing but jejunal loops. So when we talk about dilated bowel loops, how we go about identifying is, first of all, your first approach is small bowel versus large bowel. So why it can't be transverse colon? What kind of loops, what kind of folds does transverse colon or large bowel have? Large bowel will always have incomplete folds called gastrations, right? So this is your first basic step, that is you recognize large bowel by these incomplete folds. Jejunum you identify by complete mucosal folds called valvulae conniventus, valves of Kerr-Green, concertina effect. All of these are names which have been used to describe it. Duodenum you identify based on the location. It will have the C loop based on which we recognize it. Ileum typically is featureless, right? So ileum neither has the complete folds or the incomplete folds. Yeah, so this is what is the jejunal bowel loops. A repeat from FMG exam, a repeat from like multiple papers. Intestinal obstruction is a topic that is always gonna show up. All right, so that is our takeaway from the first question, answer being jejunum. Second question, image-based question again. A 30-year-old female presents with sterile pyuria. So you'll notice in most of these image-based questions, they have given you a lot of clues, guys. They've given you a lot of clues. Wherein once they give sterile pyuria, that gives you a very big hint that they are likely talking about tuberculosis. And then when you go and look at this image, wherein one of the kidneys completely calcified, there's this complete lobar calcification of this kidney, as most of you are correctly saying, is definitely patti kidney. So patti kidney means a completely calcified kidney, which is the end stage of tuberculosis. So it marks the end stage wherein there is no active infection, there is complete lobar calcification. Alright, so this is what is patti kidney. Alright, apart from that, why not nephrocalcinosis? Nephrocalcinosis will just have either cortical calcification. If it's cortical nephrocalcinosis, it will have medullary calcification if it's medullary nephrocalcinosis. Right, so obviously I don't have the exact image. We try and be as close as possible, but I did not set the paper, so I don't have the exact images, right? So you go as close as possible, you take out the learning point, and that is the whole point of this exercise, to learn for future examinations, not to find the exact paper and leak it. Right, so this is nephrocalcinosis. Staghorn calcification, Staghorn calculus is going to do what? It's going to form, it's going to take up the shape of the pelvic calyceal system. So it's going to seem somewhat like this. So you won't see the lobar type, you will see the shape of the pelvic calyceal system in a Staghorn calculus. Psoas calcification, so this is the psoas muscle shadow on the X-ray, and this is where you would find calcification if it was there. Alright, so this is patti kidney. Okay, next. A child undergoes prophylactic irradiation as preparation of bone marrow transplant for the treatment of ALL. Which of the following is affected least? So again, a direct question molded in a form of a clinical scenario and everything. Eventually they're asking that which is the least radio sensitive, isn't it? Again, something that we've discussed so many times in our last few sessions only, that the least radio sensitive, how do we remember the order? It's always going to be bone marrow, hematopoietic cells, which is the most sensitive, followed by GI, which is the intestinal epithelial cells, and then we are going to have CVS and CNS, which is the least radio sensitive, right? So neurons are something which are the least radio sensitive, or which are affected the least by radiation. Sperms, again, rapidly dividing. So the point is Bergoni's law, that whichever cells are constantly dividing are going to be radio sensitive. So again, logically, no need to remember facts. Sperms dividing, mucosa dividing, constant repair, bone marrow constantly dividing. So they are radio sensitive. Neurons not dividing, quiescent cells. So that is why that basic concept will help you answer this question. Alright, so this is neurons. Next, a child presents with cyanosis. X-ray of the patient is given. What is the likely diagnosis? So, straightforward question. Yeah, you cannot say that these are all difficult questions. They aren't, isn't it? So, what we are seeing here is this figure of 8 appearance. So, here there was one slight trap for you. What was the slight trap that they've given? Cottage loaf, but the diagnosis is wrong, isn't it? So this particular appearance is called the snowman sign. It's also called as cottage loaf. It's also called as figure of 8. But the diagnosis is going to be TAPVC. Yeah? Yes, 12 years is possible. Alright, so supracardiac TAPVC may present in the first or second decade. Alright. So that is possible, yeah. So yeah, all right. So this is definitely B. It is not truncus although cottage leaf is correct, but cottage leaf is with supracardiac TAPVC. So what is TAPVC? Totally anomalous partial venous, totally anomalous pulmonary venous communication, wherein the pulmonary veins, instead of draining on the left atrium, they are gonna combine to form this vertical vein, which goes and drains in the brachiocephalic vein, which drains in the SVC. So that is the genesis of this shadow, this figure of 8 appearance that we are seeing. Okay. So this is what is answer B, pretty straightforward. All right. In TGA, you will have an Agon side wherein superior mediastinum is very narrow. Will be very narrow, and then you will have, so somewhat like exactly opposite of what you are seeing, a very widened mediastinum in this case. Therein will be a very small narrow mediastinum. All right. On Egg side, and boot-shaped heart, everybody knows, will be very typically identified. All right. So this is about congenital heart disease. Next, again. So just tell me if this was actually given in the question. A 9-year-old male was brought to the ED by the mother with difficulty in swallowing for the past few hours. Did they give that also in the question, that the baby had difficulty in swallowing? Because if they have, that is like a giveaway. I mean, I don't see any point of asking the question only if they've given ki swallowing में difficulty tha, and then you are asking whether it's in trachea or it's in esophagus. राइट, सो देन दिस अ गिव अवे, राइट, दिस इज अ गिफ्ट की ले लो, ये आंसर, ये हम दे रहे मार्क्स आपको, है ना. सो दिस इज लाइक वेरी इजी. For past few hours, he was noted to play unsupervised. X-ray was taken, identified. Plus, what I have not included here, they had also given the lateral view from what I have heard from a few students. कि lateral भी था, AP भी था, ये भी दे दिया कि difficulty in swallowing भी है. So this is something that you can't get wrong, है ना. तो this is in esophagus. How do we recognize it? We recognize it on the frontal. So for future purpose, you will not get a question like this. इतने क्लूज नहीं होंगे. They'll give you just a frontal radiograph, and if I tell you कि ना unsupervised play है, ना difficulty swallowing है, ना lateral है, is this just this enough images enough to make the diagnosis? Answer is yes. So what have we learned? So if you see the foreign body end face, है ना, पूरा का पूरा end face दिख रहा है, then it is in the esophagus. But if it is like this, if it is a slit, if it is a laterally placed X-ray, then it is trachea. So for future examinations, remember, इतना आसान नहीं होगा. Okay, so remember ऐसे. Or lateral is very clear, wherein you see it in the trachea, and it's in trachea. If you see it posterior to it, then it's in esophagus. So if it's in the air-filled trachea, तो वो trachea में है, और ना esophagus. All right. So I have not given that to make it slightly more tougher, to make it slightly थोड़ा अच्छा question. All right. So this is esophagus. Okay, guys. Fair enough. So easy question. Next. Patient presents to ED with chronic ear discharge and headache with ear pain. CT reveals the following findings. So what are we having? We know this is CT because the bones are white, plus they've given, and we've also given contrast. So this is a contrast enhanced CT in which what we have is a ring enhancing lesion. Do you recognize this? Everybody could recognize that this is what we call as a ring enhancing lesion, that there's peripheral enhancement that we are seeing. Where is it located? So it's located in the temporal lobe, isn't it? So this is the medial temporal lobe that we are having, the temporal abscess. So this is indirectly a radiological anatomy combined with ENT kind of questions. So this is going to be how the questions are going to come irrespective of the exam. चाहे आप NEET दे रहे हो, INI-CT दे रहे हो, you'll have a combination of different subjects, right? So this is definitely temporal abscess. It is not extradural. If it was here, फिर आंसर क्या हो जाता? अगर यहाँ पे ring enhancing lesion मिलता, फिर आंसर C होता, है ना? Because then it becomes cerebellar abscess, right? Subdural, again you would see something extraxial, you wouldn't see in the parenchyma. ठीक है, so kind of easy. So this is temporal abscess. Okay, next question. Again, easy question. 30-year-old male complains of gradual swelling around the wrist for 3 months. X-ray is given below. What is the most likely diagnosis? And I'm not saying easy just to ऐसे कि questions इतने easy थे, but they're actually easy, you know. So don't be like that कि सारे गलत हो रहे हैं. Anyways, so these are easy questions. What are we seeing here is, this is an epiphyseal lesion. So anytime they show you the distal end of radius and you see an epiphyseal lesion, this is something which has been going on for years and years. The same question, this is GCT, right? So our approach here is going to be epiphyseal are two lesions, chondroblastoma, giant cell tumor. So remember, all the juniors who are watching this is a question you just can't afford to get wrong. When you have a 30-year-old male patient, epiphyseal lesion, giant cell tumor is your possibility. Particularly, it further you get confidence when you see that distal end of radius is given. Okay. In fact, I don't think chondroblastoma was there in the options. Options were also such that they did not even give you a chance to get confused कि कहीं ये chondroblastoma तो नहीं है, कहीं ये aneurysmal bone cyst तो नहीं है, because those are the two common DDs that we'll consider, है ना. So chondroblastoma is something that you will see with skeletally immature patients. All right, so it will be a lesser aggressive tumor which will be localized exclusively in the epiphysis. It might have calcification, so that is how chondroblastoma will appear. And what about ABC? ABC will also have a lot of trabeculations, but ABC will be metaphyseal, remember. Alright, so this is giant cell tumor for you. Question number 8. 26-year-old male with backache, morning stiffness and reddening of eyes. X-ray of the patient, chondroblastoma was there. Fine, a lot of you are saying chondroblastoma was there. ठीक है, so which one was not there? Anyways, doesn't matter. But if that was there, still you can rule it out because it will be seen in an older, in a younger child with localized lesion. Okay, right. So here a very typical history of Anspawn, a young man with backache, stiffness, which is inflammatory backache, and uveitis-like features. And what we look at the X-ray is this complete ossification of the interspinous ligament. We see that all the joints are fused. So this is what? This is the tram track appearance that we have learned, or also called as the dagger sign because of this calcification of the interspinous ligament, or the bamboo spine wherein you have complete ossification. All of these point towards ankylosing spondylitis. Plus, you also see that the sacroiliac joints are fused. There is complete ankylosis of bilateral SI joints. Hence, this cannot be anything but Anspawn. Rheumatoid arthritis, if it has to affect the spine, it will affect the C1, C2 atlantoaxial joint. Psoriatic arthritis can also have such features, but they'll give you what? They'll give you associated findings of psoriasis, because that can also a lot of times give rise to seronegative spondyloarthropathy, but pretty typical history with Anspawn. Paget's disease will not have this fusion. It might have multiple lytic sclerotic lesions, but it will not have this fusion. Okay, so that is how we can rule out other options. Okay, so you had two questions on the same topic, isn't it? Another question, a young male 20-year-old patient with chronic low backache, early morning stiffness since last 2 years associated with bilateral heel pains. So here again, extremely typical history wherein they have given the same kind of problem wherein he had this inflammatory kind of backache and bilateral heel pain. So what does that point towards? That will point towards enthesitis. Enthesitis is a very, very typical hallmark that they'll give you for Anspawn, isn't it? So this is again Anspawn, and a lot of times we question ourselves in the exam just because two questions have the same answers. That can't be possible. So most of us, a lot of us would have changed. है ना कि दूसरे में let me overthink and change my answer. It's not possible that examiner has done the mistake of giving two answers in same question, right? So if you have changed your answer on that basis, don't do that. Such mistakes can happen in the paper. In fact, you can also have repeated questions. Same question बार बार आ रहा है. ऐसी चीजें भी होती है. Alright, so you have to remember, don't change your answer on the basis of the whole paper, right? So you see every question one at a time, है ना? तो वैसे करके करना है आगे से. So this is Anspawn. Okay. Next, so that is why, what did I tell you? Overconfidence, underconfidence. कुछ भी नहीं करना such that we change, है ना? Overconfidence में कि examiner cannot give me two questions with same answers. Yeah, so don't change on this basis. That is our learning point now, right? Next question. 10-year-old child with normal bone mineral density. X-ray is given below. Identify the diagnosis. So again, when we look at joint disorders, two main possibilities we always get confused is rickets and scurvy. है ना? So what is it? So on what basis do we? Thank you, Samarth and Ayush. So what we are seeing here in this image is the metaphysis, and so this is the epiphysis, this is the metaphysis, and the yes, splaying was present, right? So this also is splaying, right? In the way that you are seeing that the metaphysis is widened, but the hallmark that you're seeing here is 2 points, very, very important. Okay, pain was mentioned. That is again a big clue towards scurvy, isn't it? So pain is associated with scurvy because of the presence of subperiosteal hemorrhages. So you have that pseudo paralysis in scurvy. So again, pain goes in favor of scurvy. Just on the basis of X-ray, there are two very important features that you look at to distinguish rickets versus scurvy. I know there are 1,000 named signs for scurvy. They are not going to come and rescue us in the image. What is going to come and rescue us is look at the metaphysis. If the metaphysis is sclerotic, all right, if it is white, if it is dense, that is scurvy for you. And what is this line called? That line is called white line of Frankel. On the other hand, in rickets, you are not going to have this density which is increased at the metaphysis. In rickets, you will have metaphysis which is not white, it is lucent. Alright, so you will have irregular metaphysis, but it is not going to be white. When can it be sclerotic? So sclerotic metaphysis can be seen in rickets once it is healing, once it is being treated. So remember, this is the hallmark. Apart from that, what we are looking at here also is this epiphysis, which is very well defined, which is called the Wimberger sign. So again, this well defined epiphysis, normal epiphysio-metaphyseal distance, all of these are features which go in favor of scurvy over rickets. Okay, so that is what is important. So the answer here is scurvy. Osteopetrosis, it cannot be, because osteopetrosis will have diffusely increased bone density. It will be completely white bones. All right, so it can't be that. Metaphyseal dysplasia is a good possibility, but metaphyseal dysplasia, remember, will affect all the metaphyses. All right, it will affect all the metaphyses. There will be no whitening, there will be no sclerosis, there will be just irregularity of metaphyses that you will find. All right, so in any case of such kids, such images, three possibilities are considered: rickets, scurvy, metaphyseal dysplasia. The moment you see sclerosis, the moment you have associated pain, go in the lines of scurvy. Okay, so I hope this is what is asked. Yeah, I did tell you, isn't it, Jason, if you've been following my classes, that FMG exams are going to be very difficult. So for those of you who've been studying for like with me since the last few days at least, if I did tell you to solve the last two FMG exams. If you did, many questions were repeated. So the obstruction jejunum question was a direct repeat. Posterior hip dislocation was a direct repeat. This was a direct repeat, rickets, scurvy. So many questions just came directly from the FMG exams, because it's the same question bank, it's the same board which is setting. So that is why it's important to do those papers. Anyways, 20-year-old female presents with webbed neck and shielded chest. Which of the following investigations and findings is most likely? So very typical history: webbed neck, shielded chest. We are talking about Turner's, and Turner syndrome will have streak ovaries on ultrasound. Streak gonads is a feature of Turner syndrome, right? So cardiomegaly, very unlikely. These patients will likely have coarctation of aorta, which is associated, but cardiomegaly is not a feature. Mitral valve prolapse, subluxation, you would consider with Marfan's and not with Turner syndrome, right? So these are pointing towards Marfan's. And yes, you did get one more question on Turner syndrome, which was again very similar, very direct, wherein they asked you to diagnose Turner syndrome. So again, two questions coming from same topic, which is repeating twice, isn't it? Right, 12th question. 6-year-old child with hypertension. Lower limb pulsations were feeble, upper limb were normal. On X-ray, rib notching was seen. So extremely typical hallmarks of coarctation of aorta. All the possible clues they have given of brachiofemoral delay, rib notching, right? So again, very easy question, coarctation. Even look at this, that congenital heart diseases were repeated twice, isn't it? So you have a question on coarctation, you have a question on TAPVC, both of which are pretty straightforward questions. Going ahead to the next one, 35-year-old lady using OCT since 5 months, presents with amenorrhea since 6 weeks. Which is the best to calculate the gestational age? So always remember, out of LMP, physical examination, it's always going to be ultrasound, which is CRL, it's going to be most accurate. In fact, if I just have to add on for future examinations, remember, anytime you want to calculate the gestational age, what is the time period which will be the most accurate? The time period is always going to be first trimester, which is most accurate. wherein you have CRL that will measure, that will give you the highest accuracy. In the second trimester, you go ahead with a biparietal diameter so here the accuracy keeps falling as you keep delaying the dating, alright. So if you go into second trimester, the accuracy is lowest in the third trimester, wherein you rely on the femur length. Some people also use BPD here, so there are two possible answers here, but the accuracy keeps falling, so there is no doubt CRL is the most accurate feature. Alright, so this is about that. Next is again a direct repeat from last year NEET examination. Identify the examination. So when we see background में there is this X-ray, it is nothing but a conventional hysterosalpingography. Okay? Yeah, correct. So hysterosalpingography, it is not laparoscopy, it is not hysteroscopy. Something that might have confused you for a bit is saline infusion hysterography, which sounds thoda sa correct like, but saline infusion hystero or saline infusion sonography will be something wherein you use ultrasound as the background. You won't see saline passing on the X-ray, isn't it? It won't appear white. So when you are seeing this white contrast within the uterus, it is absolutely hysterosalpingography. They can also give you conventional hysterosalpingography. Yeah, so same thing. Okay, yeah, normal saline histogram, same thing, right? Rockstar, same saline infusion, normal saline. So it is when you will see ultrasound in the background. Okay, thank you so much, Akansha. So this is hysterosalpingography. Yeah, next, many questions from gynae radio. 25-year-old female with primary infertility came to the hospital with uterine anomaly, which is the confirmatory investigation. So remember, gold standard or the best investigation that you have for any Mullerian anomaly is going to be hystero plus lapro, because you want information about the outer contour, you want information about the inner contour. It's going to be B, not laparoscopy alone, not TVS, not HSG. Alright, so remember, Mullerian anomalies, if they ask you investigation of choice or how will you evaluate it best non-invasively, then you have two options in the form of 3D ultrasound and MRI, but always the gold standard to confirm, it's always going to be hystero, laparoscopy. And yes, they were kinder to you by not giving these in the options, because then it would have definitely confused us. What are they trying to ask? Then it goes into semantics and logistic issues, which sounds better, because investigation of choice agar पूछते हैं, we consider this because it is non-invasive. Yeah, femoral bypass question. What was the femoral bypass question? I think that's surgery question. उसको end में एक बार देखते हैं ना, remind me just. So question 16, 35-year-old male working with hammer and chisel had an accident and a foreign body enters the eye, which will be detrimental. So this is something that is directly from our thumb rules. In fact, just one day before the exam in the plus class, we were discussing this, that thumb rules are very important. We discussed this thumb rule. MRI, never ever do an MRI in a foreign body. Alright, something which is very basic. So foreign body ka what is our rule? The initial investigation, X-ray. The best investigation, CT. Ultrasound can be useful for superficial foreign bodies, for ophthalmic foreign bodies. Now, one very funny comment that I had read somewhere, or one opinion that I had read somewhere, was that you would not do ultrasound in ophthalmic foreign body because of the pressure of the probe, it will further get pushed. No, we don't apply so much pressure that foreign body will go into the brain or anything. Alright, so that is a completely wrong train of thought. It is MRI, because this foreign body can be metallic, and what can happen here is you will have harmful effects. It's detrimental, it is contraindicated. Alright, so as I keep saying, what not to do is going to be more important than what to do. So you need to know that this is something which you will never do, which is MRI. Alright, going ahead to the next one, image based question, thoda radio anatomy type ka question. CSF shunt wala ka bhi I don't really know the options. The options were confusing in that question, right? So just tell me the exact question, फिर उसको करते हैं. A patient diagnosed with spinal TB had a swelling in the left groin with limb attitude in flexion. So that flexion deformity likely with spinal TB is because of a psoas abscess. Alright, so I have not put the options. So if these were the options A, B, C, D, so this muscle here in a coronal CT, first of all, everybody could identify coronal CT. The bones are white, it's a coronal plane, these are the kidneys. So these two muscles that you see here are the psoas muscles. So the answer here is going to be A, psoas muscle. The muscle B here, which is along the iliac crest, is the iliacus muscle. This outer muscle is gluteus maximus. Option number D is gluteus medius. Alright, so it's going to be the psoas abscess in the case of spinal TB, which is causing this flexion deformity. Okay, so the answer here is going to be option A. Next is a 60-year-old female with increased bowel sounds. Tell me here, there's no image, right? It's just a description that X-rays revealing dilated small bowel loops and air in biliary tree. इसमें कोई image नहीं था, right? She had a history of hysterectomy 2 years ago. तो ये थोड़ा अच्छा question था, wherein they are trying to actively confuse you and take you towards some other answer. So when they give you hysterectomy, when they give you post-op, तो अपने को लगेगा कि adhesions होंगे resulting in small bowel obstruction. But what they have given a big clue which completely changes the answer is air in the biliary tree, which is pneumobilia, है ना? So small bowel obstruction probably यहाँ पे लिखा होगा secondary to adhesions ऐसा करके कुछ right? So, but when they give air in the biliary tree, that you won't see that in small bowel obstruction, right? So air in the biliary tree is definitely pneumobilia. They are talking about Rigler's trial, right? So ये थोड़ा अच्छा question था, wherein the answer becomes gallstone ileus. So when you have pneumobilia, SBO, and you might see a radiopaque gallstone per se in the ileocecal junction causing the small bowel obstruction, or you may not see it. That is Rigler's triad of gallstone ileus, right? What goes against small bowel obstruction due to adhesions is again air in the biliary tree. Mesenteric ischemia, will it have air in the biliary tree? No, it will have what? It will have portal venous gas, isn't it? So gas can translocate into the blood vessels if you have ischemia which is very severe, you know. So then it can go into portal vein, just like we see with what? This is something that we also see with necrotizing enterocolitis, isn't it? So जैसा pathophysiology NEC में है, वैसा ही pathophysiology can result with mesenteric ischemia, and then you can have portal venous gas, but not in the biliary tree. Large bowel obstruction तो बहुत ही ऐसा है because dilated small bowel loops they have given. ठीक है? 19th question. So already 19 questions. I hope you guys have done well. All of these questions are pretty straightforward, isn't it? 55-year-old hypertensive male with acute chest pain, loss of consciousness, diaphoresis with unequal pulses in bilateral upper limbs. Is this the kind of question that you had? ऐसा question stem था? I have done some opthal fundus images we've taken in one Midnight Express only before in first week of September we've done that. So this is what they've described here is an aortic dissection. So they've given you a clue in the form of a hypertensive male who's now having chest pain, diaphoresis, unequal pulse, likely because one of the dissection flap would be entering into one of the subclavian arteries that is resulting in this unequal blood pressure in the upper limb. So what is the best investigation in the emergency setting? Yeah, so when they give you emergency setting, although they haven't given you any other option of CT angio, here the answer for aortic dissection becomes TE. So we've learned that aortic dissection investigation of choice, if it's an unstable patient, the best is TE, which can be done bedside. Transesophageal echocardiography can be done in the bedside. You don't have to shift the patient. If the patient is stable, having stable vitals, you have to go ahead with CT angio, which will be overall the best investigation to see the extent of the dissection, the type of dissection. Here they were very kind to you in not giving this as an option only, isn't it? CT angio tha option mein. From what I have heard, it was not in the option, which makes your diagnosis pretty straightforward. But yeah, they had given ST elevation changes also. That can also be possible, isn't it? Do you agree in an aortic dissection you can also have secondary ST elevation changes or MI-like changes? It is possible because of the pulse were non-palpable. Fine. Still, your answer doesn't change, right? So because of ST elevation changes also, you can have a dissection flap which is extending into the aortic inlet, right? So that is how, even if they give you, that was again something that was taking you towards myocardial infarction. But when they give you other features here, like the involvement of loss of consciousness, unequal pulses or non-palpable pulses, where they're telling you that there is one flap which is involving a lot of branches of the aorta, like the carotid, like the subclavian. So this is what is favoring aortic dissection here over cardiac enzymes, which is myocardial infarction. Alright, so that is why answer here is TE. Alright, 20th question. I didn't get the exact image that a lot of you described, but let's go through this. This is slightly doubtful. 35-year-old male with fever and uneasiness since 2 to 3 days with acute pain abdomen. What is the likely diagnosis? So there were few things which were very clear from the description of the images that you guys gave. There was a lot of air under the diaphragm. Yeah, there was a lot of air. इसके basis पे मैंने ये image लिया. And you also had an NG tube which is going into the stomach. Yeah, so, and correct, there was no air on the left side is what you told. So I couldn't find the exact image, so I brought you two images. This is where you have just small amount of air here, and then you have no NG tube in this image. Alright, so it was a combination of these two, but overall the point being, when you have air under the diaphragm, it is nothing but perforation. Alright, and one supine X-ray. Yeah, so it was a combination of supine as well as erect. So I couldn't find that image exactly, so probably from somebody's collection that must have come up. So this is likely to be perforation. All right, so air under the diaphragm, perforation, and perforation is a question which has very high pre-test odds of getting asked. So if I don't have the exact image, I would still go ahead with perforation. Alright, so that is something which is there. A lot of you are thinking it is volvulus, but volvulus will not have the NG tube which is there, alright, which is there on the left side. So NG tube के लिए, I mean volvulus के लिए your NG tube will also go along with that air under the diaphragm, alright, if that was indeed a volvulus. So that is very unlikely. Okay, so likely is perforation. Yes, so gradual onset pain can also be there, isn't it? Before complete perforation happens, there can be some amount of pain because of the hollow viscus which is inflamed, and then it can perforate. Alright, so it can be preceded. It's never कि अभी के अभी pain हुआ and अभी के अभी perforation. You always be preceded by some subacute symptoms always. Okay, and then it gets severe once there is complete perforation. So that is okay. Alright, so that is what is there. Yes, a lot of you are भाई मतलब मुझे इसमें थोड़ा सा doubt है, because a lot of you are saying that it was like a air fluid level. It was like a horizontal air fluid level under the diaphragm, and that is kind of making me think about liver abscess, because this patient also had fever, or like this patient also had fever. So a lot of times what can happen is that one mimic, alright, one thing which mimics perforation is a liver abscess. A lot of times if liver abscess is big enough, what it will do is, this is the diaphragm, you will see like this. So here you will have the air, and here you will have the soft tissue density. So if there was a horizontal level, I kind of think it could have been liver abscess, but we don't have the exact image. And because perforation is something that they always ask, I am kind of in between. So basically this is something which is slightly doubtful, but a lot of you are saying that it is not, there was no fever. If there's no fever, then you go ahead with perforation. But yeah, these are two possibilities here. Alright, so this one is doubtful because we don't know the exact image that was asked. Okay, right, yeah, only NB knows here. Okay, chalo. Empyema thoracis is something that you will not see like this, will as air under the diaphragm. It will have some sort of effusion, and then it has a draining sinus through the skin. That is what is empyema thoracis, wherein you will find empyema, you will find pleural effusion, and in empyema necessitans you can have a draining sinus also. Okay, तो वो तो consideration है ही नहीं, तीन possibilities है इधर. We need to know the exact image. This reminds me of INI-CT, wherein again we were struggling with that gastric volvulus image for the longest time. We still couldn't find the image. So हमेशा ही volvulus, whenever volvulus comes into picture, there is controversy. So I don't know, I never thought perforation would be controversial, but some image has issues. Alright, so here consider this plus minus in your counting, if at all you are counting. Next, 40-year-old male with acute pain abdomen, presence to the ED. A fluid-filled lesion was in the epigastrium. So again here no image was given of pseudocyst. Did they give you any pseudocyst-like image? शायद तो नहीं था. So what is this? So this is pseudocyst with acute pancreatitis. Yeah, so pseudocyst, acute pancreatitis. The abnormal investigation is going to be lipase. Alright, so answer here will be lipase is what you will do to confirm acute pancreatitis. ठीक है, no image. किसी को doubt नहीं था इसमें कि और क्या हो सकता है? So this is acute pancreatitis, pseudocyst. ठीक है, तो I think this is cool. इसमें तो कोई controversy नहीं है, thankfully. Can we get question paper from NB? So Nikhil, you can try. If you do get it, let us know. Next, 30-year-old man post RTA with flank ecchymosis with stable vitals. Which of the following investigations is the best to localize the site of bleed? So flank ecchymosis, RTA, they are likely pointing towards renal injury, right? So renal injury, were there any other clues here for renal injury being the likely cause? But despite that, if they ask you the best, anytime in trauma, they ask you what is the best to see liver injury, renal injury, splenic injury, answer is always going to be CCT. Investigation of choice in a patient who is stable to detect the site of injury is always going to be CCT, no doubts about it. Just on your basic principle of trauma, like trauma का basic किया है ना, you could answer 3 questions. 3 questions for trauma were direct basics. Alright, so this is definitely CCT. Alright, so fast was also in the option. Yeah, so ultrasound or fast doesn't change your answer. Fast is not the best to localize injury. Fast is the best as initial investigation to know whether there's hemoperitoneum or not. So one more time, what I want to tell you is, first, anytime a patient with blunt trauma abdomen is coming to you, the first investigation everybody gets, whether they are stable or unstable, is going to be EFAST. So when they ask you initial, चाहे patient stable हो unstable हो, go ahead with EFAST. फिर अगर patient stable है, what will you do next? You will do CECT. So if they ask you best, it is CCT. If the patient is unstable, EFAST is positive, you take the patient for OT. Alright, so this is the approach that you have to remember. Okay, so here answer is CCT. Next, urethral trauma. No, there's one more patient. So जो आप लोग बात कर रहे हो was this question. So let's take up this question first. 35-year-old male with RTA with BP 90/60. So this patient is unstable, है ना? What is the next appropriate investigation? So do you see the difference between the two? So here they have an unstable patient and now they are saying कि next क्या करोगे? So here your definite answer is EFAST. Do you guys agree कि ऐसे 2 सवाल थे? And I am not making these up. I hope these 2 questions were there. This is EFAST which you will do whether patient is stable or unstable. यहाँ पे मैंने vitals अगर आपको stable भी दिए होते, your answer would still have been EFAST. Okay, not CCT. DPL is no longer done, almost extinct. Nobody does diagnostic peritoneal lavage anymore. It has been replaced by EFAST. Okay, ठीक है, तो ये है 2 क्वेश्चन. इसके अलावा one more question on trauma was on urethral trauma. Urethral trauma, as I keep stressing, how many times have I taught urethral trauma? It's very, very important. 13-year-old boy presents to trauma center after skid injury and he is unable to pass urine with blood at meatus. So very typical history. एक तो skid injury है, हो सकता है urethral trauma हो, not able to pass urine, blood at meatus. So what is the clinical triad of urethral injury? Unable to pass urine, blood at meatus and high riding prostate. Now tell me, do we still find this high riding prostate? कैसे पता चलेगा? That is done by digital rectal examination. But is this something which is considered to be a correct line of management? No. So according to recent ATLS guidelines, we will never do DRE in a patient with suspected urethral injury. So these are the 2 pointers that you have. अब option में बताओ जरा, Foley's SPC. Options are Foley's SPC. अच्छा, MCU CCT नहीं था. It was nephrostomy and ureterostomy. Perfect. ठीक है. So they have removed one thing. So now tell me clinically, भूल जाओ question को. अभी मुझे बताओ, when you have a patient with suspected urethral injury, what will you do next? Is it either of these? No. Next you would do an RGU to confirm whether urethral injury is there or not. But RGU clearly was not in the options, isn't it? So RGU अगर positive है, if that shows you urethral injury, then you go ahead with suprapubic cystostomy. So suprapubic cystostomy means that you directly put a catheter into the bladder percutaneously. So if through the abdomen, it is the abdomen sagittal of the patient, percutaneously in the bladder a tube is put. Okay, so that is the thing that you will do when there is urethral injury. Again, in life, what is more important to know is what not to do. So what not to do here is Foley's. Never ever put a Foley's catheter in a patient with suspected urethral injury. one dictum, absorb it into your system. If you have marked Foley's, this is a bad mistake to have made. Okay, so Foley's catheter कभी नहीं डालेंगे, because even if your patient has partial urethral injury, you try to put in a Foley's, you would have aggravated the injury to maybe a complete urethral injury. So never attempt Foley's. Answer here is suprapubic cystostomy, because RGU is not in the option. If RGU is in the option, that is the best next step. Correct? हाँ, वो एक और सवाल है ना अक्षय. That was the fourth question which you had on trauma. So you had 4 questions on trauma which were there. So shall we? I did not have that exact question, but as you've written, so there were absent breath sounds in that patient. Patient was very unstable, isn't it? So let's like just try and unravel this question. Absent breath sounds था, patient was unstable, and आपसे पूछा था what will be the next step. So I think उसमें fast was one option, needle thoracostomy was one option, बाकी दो क्या था. But anyways, when you have an unstable patient with absent breath sounds, you go ahead with needle thoracostomy. You don't wait for fast, you don't wait for chest x-ray, you don't wait for CCT. It is always a clinical diagnosis. Alright, so here the next step is needle thoracostomy, a question which has been repeated over the generations, ancient question which you can't afford to get wrong, है ना. तो shock भी था patient को, hypotension भी था, so you go ahead with needle thoracostomy. There is no doubt about it. ठीक है. तो in conclusion, don't get confused by your paper. There were 4 questions on trauma. एक था कि अनस्टेबल पेशेंट में नेक्स्ट क्या करोगे, यू विल से फास्ट. ठीक है. एक था रीनल ट्रॉमा बेस्ट व्हाट इज इट, यू विल से CCT. एक था क्या था, यूरेथ्रल इंजरी, wherein they gave you clinical history of urethral injury. They asked you next, you will say कि RGU करेंगे, but आपने RGU ऑप्शन में दे दिया, I will do SPC. चौथा क्वेश्चन था of this patient, unstable patient with tension pneumothorax, what will you do next, you do needle thoracostomy. ठीक है. अगर IV fluids भी था ऑप्शन में, still tell me what will you do first, A, B, C, D, E. Does C come first, B comes first? You will do needle thoracostomy. This patient is dying of breathing problem, right? So first do a needle thoracostomy, decompression. ठीक है. ठीक है, कुछ प्रॉब्लम हुआ. फ्लैंक एक्यूमोसिस वाले में फास्ट ऑप्शन था तो ठीक है, वो बेस्ट नहीं हुआ ना अक्षय, वो बेस्ट नहीं हुआ बिकॉज बेस्ट इज CCT. फॉर एनी लोकलाइजेशन टू किडनी, लिवर, स्प्लीन, इट विल बी CCT, नॉट फास्ट. ठीक है. वन ऑप्शन है IV फ्लूइड्स प्लस नीडल थोराकोस्टमी, फिर तो बेस्ट है. सब कुछ ही दे रहे हैं तो फिर तो यही मारेंगे. ठीक है. एवरीबडी अग्रीज. तो ये सवाल 4 ट्रॉमा से क्वेश्चन विच इज लाइक हाइट्स. सो ट्रॉमा इज वेरी वेरी इंपॉर्टेंट. इवन इन INICT यू कैन गेट लॉट ऑफ क्वेश्चन. 4 जितने तो नहीं आएंगे, बट 1 और क्वेश्चन ऑलवेज कम्स. ओके. ओके. नेक्स्ट. सो क्वेश्चन 24. 50-year-old male with dyspnea and elevated eosinophil count of 5000. This was something जो थोड़ा सा tricky था, तो ये अगर गलत हुआ है तो भी you can excuse yourself. Chest X-ray shows miliary mottling. What is the likely diagnosis? So, miliary mottling सुनते ही मेरे दिल से आवाज़ आती है miliary tuberculosis. But miliary tuberculosis will not have elevated eosinophil count, so that obvious one is out. Asthma will not have miliary mottling, that is also out. Chronic HSP, chronic hypersensitivity pneumonitis. When I hear the word hypersensitivity, my logical brain will tell me hypersensitivity type 1 होगा, it will have elevated eosinophil count. तो ये तो हो सकता है. Tropical pulmonary eosinophilia, name itself has eosinophilia. So tell me, how many of you were stuck in between these 2 options going inky pinky ponky, इनमें से कौन सा चूज करे जो कि आंसर होगा. Fine, that given nocturnal cough and wheeze. So now the correct answer, the train of thought here is when hypersensitivity pneumonitis becomes chronic, it becomes a kind of fibrosing lung disease. You will not see miliary mottling, you will see fibrosis, you will see reticular opacities in the lower lobes. It will look like an interstitial lung disease which has fibrosis. So unfortunately your answer here is, fortunately for some, is tropical pulmonary eosinophilia. TPE is a disease which has migratory opacities. So the hallmark here is migratory opacities which will be transient. आएंगे फिर चले जाएंगे फिर कहीं और आएंगे. So they are migratory transient opacities that you will see. and it will have eosinophilia and miliary mottling. Matlab shadows, like it can mimic miliary TB. So it can have reticulonodular opacities. That is the typical word. Alright, so even if you got this wrong, ठीक है, अपने आप को माफ कर सकते हो in this question at least. Alright, so this is tropical pulmonary eosinophilia. Alright, everyone? Yes, exactly. So somewhat one more reason is HSP chronic stage will anyways not have eosinophilia. Alright, but hypersensitivity के वजह से बोला. Okay, ठीक है. Finally, so these were the 26 questions. There are many other questions which I wanted to include. फिर मुझे लगा नहीं ज़्यादा हो जाएगा, so I didn't include. But so many questions we've covered in our classes, like from other subjects also. But these are exclusive things which you could solve based on a small, chotu cute subject like radiology. So I think from now on, I want all of you to pay more attention to radiology. It can get you 1/8 of the paper correct. Don't you think so? So I will see you all in the radiology classes. So thank you so much, guys. और हाँ, पढ़ती हूँ. RT वाला question, patient comes to ED, left hypochondrium ecchymosis. This was the same patient. Aren't you combining two patients? Left hypochondrium ecchymosis, absent left heart sound. Which investigation you do to confirm the diagnosis? ये कौन सा क्वेश्चन है? ये तो एकदम ही नया सा वर्जन निकाल दिया, कंबाइनिंग टू थिंग्स वेयर यू हैड एकीमोसिस आल्सो एंड यू हैड एब्सेंट ब्रेथ साउंड्स. तो अगर ऐसा सवाल था, फिर फास्ट अगर ऑप्शन में था या ई फास्ट था ऑप्शन में? बिकॉज फास्ट विल नॉट डायग्नोज न्यूमोथोरैक्स फॉर यू, ई फास्ट विल डायग्नोज न्यूमोथोरैक्स. अब मुझे लग रहा है ये थोड़ा क्योंकि कोई अग्री नहीं कर रहा तुम्हारे क्वेश्चन से, कर रहे हैं लोग. सो देन यू गो फॉर fast, then you go for chest x-ray, not fast, because fast will not diagnose pneumothorax, e-fast will diagnose. Yeah, does it make sense? तो फिर अगर ऐसा सवाल था तो मैं तो chest x-ray मारती उसका आंसर. How does that sound? तो ठीक है, ये एक नया, he has combined two questions. Alright, फिर femoral bypass. जो femoral bypass था, ठीक है, तो ultimate conclusion यही है ना कि फास्ट था ऑप्शन में, एवरीबडी इज अग्रीइंग, तो दैट इज नॉट द आंसर. चेस्ट एक्सरे विल बी बेटर. ओके, ठीक है, छोड़ दो अब उस सवाल को. नाउ गोइंग ऑन टू द दिस थिंग, बाईपास क्वेश्चन. सो बाईपास क्वेश्चन में यू हैड यूनिलैटरल, क्या था, इलियक आर्टरी में था, एंड यू हैड femoral artery. So when you have a unilateral iliac plus femoral artery narrowing, we have something called as task guidelines. All right. So these task guidelines help us decide कि क्या इसमें एंडोवास्कुलर स्टेंटिंग करेंगे या इसमें बाईपास सर्जरी करेंगे. राइट. सो व्हेन यू हैव दिस एक्सटेंसिव नैरोइंग, दे बिकम कैंडिडेट्स फॉर बाईपास ओवर एंडोवास्कुलर. सो द ऑप्शन विच वाज स्टेंटिंग इज आउट. ऑलराइट, सो यू विल नॉट डू स्टेंटिंग हियर. द अदर ऑप्शन यू हैड, उसमें हाँ थाई पेन था ना, ठीक है, थाई पेन था, फाइन. बट इलियक का भी नैरोइंग कुछ ना कुछ तो लिखा था, एज यू गाइज वर सेइंग कि इलियक आर्टरी का नैरोइंग दिया था. सी इफ ओनली फिमोरल, फिर तो स्टेंटिंग, फिर स्टेंटिंग करेंगे इफ ओनली फिमोरल. बट अगर इलियोफिमोरल इश्यू है, लॉन्ग सेगमेंट नैरोइंग है, देन वी गो अहेड विद एओर्टोफिमोरल बाईपास. इन दैट केस ओनली फिमोरल, नॉट इलियक. आर यू श्योर? Because if there's only femoral narrowing, then we will go ahead with. But see, thigh, उस question में thigh claudication था, isn't it? So anytime you have thigh claudication, guys, it means that thigh claudication था means that you have narrowing in iliac. जहाँ पे भी claudication है, उसके proximal segment में narrowing होती है. एक बार surgery वालों से आप confirm करो. But from my knowledge, anytime there is thigh claudication means iliac is narrow. Anytime you have calf claudication means femoral is narrow. So I have heard कि thigh claudication दिया था question में. So tell me कि वो था या नहीं. And don't say on the basis of your answer. सच बताओ कि thigh claudication दिया था नहीं. Thigh claudication was given, right? So if that was given, फिर तो हमें मानना पड़ेगा कि iliac narrowing था. Then you go ahead with a bypass, all right? Not stenting. And you will not do axillofemoral bypass here also. ठीक है, वो जब extensive atherosclerosis है aorta का, तब यूज करेंगे. Alright, so this you confirm with your surgery educator. They'll be the best to answer. I don't want to step on any toes, but that is what I feel. Okay. Buttock is when you have, along with iliac, you also have internal iliac narrowing. You have components in the aorta. So that is what syndrome? That is the Leriche syndrome, where you have aorto-iliac occlusion which has buttock claudication, isn't it? So when you have aorta also getting involved, फिर अपना बटक क्लॉडिकेशन भी होगा. समझे? तो जहाँ पे भी नैरोइंग है उसके नीचे के लेवल पे हमेशा सिम्टम्स आते हैं. ये मेरा कॉन्सेप्ट है, ठीक है? तो ये कॉन्सेप्ट अच्छा कॉन्सेप्ट है, याद रखो. ओके, सो आंसर होगा एओर्टोफिमोरल बाईपास. हाँ, इम्पोर्टेंस भी बिकॉज इंटरनल इलियाक ऑल्सो गेट्स इन्वॉल्व, है ना? अब so this was about the questions. So 27 questions we've discussed. Hopefully you will agree with the solutions, and that is what it is. So thank you guys, and I hope to see you all soon in the radiology classes on the app. If you wish to subscribe, you can use my code, which is ZVORA, for your subscription. CSF वाला question एक बार group में discuss करते हैं. We'll also try and find out from authentic sources what could be the answer. Alright, so I will let you know. So thank you so much guys, and all the very best to you for results. Don't worry too much now about कितने सही हुए, कितने गलत हुए, कितने पे क्या स्कोर आएगा, क्या रैंक आएगा, क्या सीट मिलेगा. Don't worry about all of these things, and just take a break for a few days. Try and detach from I know it's easier said than done, but try and detach from the exam now. जो हो गया, it's in the past. Focus on being happy, staying happy for a few days, and then jumping back to studies and preparing for INICT. Alright, so that is my piece of advice. I'll see you. हाँ, Midnight Express निकालेंगे. हाँ, निकालेंगे कुछ दिनों में. अभी Midnight Express ख़राब है, so it will be repaired in a few days because of overwork. वो ख़राब हो गई है, तो थोड़े दिनों बाद फिर से निकलेगी. Okay, so I will let you know. Result का idea nobody has. Who am I to tell you when NB only hasn't announced? So hopefully by end of this month, that is like something which is expected, but nobody knows. Okay, alright guys. So thank you so much. INICT के लिए पढ़ेंगे. So we have plus classes which are starting on 15th of September. So we are starting with CVS radiology integrated with medicine surgery. So whenever I will teach, I will try and integrate other subjects for you, such that everything goes in that same box in your mind. So I'll see you all very soon, and thank you so much guys for listening to me. Bye.